And so how do these circadian disruptions, how do they affect our patient's ability to take certain medications? Like, for instance, we as clinicians, right, we like to say, well, take this at night, take that in the morning. How does this play a role for us?
It's so interesting, Jerry. I mean, I think that most of us know in clinical practice, if we had a medication that's more sedating, we say take
Hmm.
it in the evening for reasons that are self-evident. A medication that's activating, take it in the morning, again, very
Yeah.
self-evident. But there's another part to this that we don't talk about in psychiatric pharmacology or pharmacology in general. I'm going to introduce a couple of terms to people joining us today, Jerry, that being chronopharmacology and chronotherapeutics. What the heck is chronopharmacology?
Yeah. Yeah.
Well, when we develop drugs, drug discovery and development, Jerry, starts off in rodents, in mice,
Hmm.
and rats.
Yep.
Well, we tend to do the studies during the daytime. That's when the lab is open, but that's the nighttime for the rodent. And in actual fact, we are testing drugs in rodents during the nighttime. It's their night,
Mm.
they're nocturnal animals. The other part of this, which is interesting, is that when you look at the body, I mentioned at the start, up to half of the genetics in the human genome are circadian. They have a circadian change. And we know, for example, if you look at pharmacokinetics, absorption, distribution, metabolism, elimination, the four pillars, if you will, of pharmacokinetics, all of these are affected in a circadian way, including phase one, phase two, and phase three metabolism in the liver. Pharmacodynamically, it's much the same thing. In other words, we know that our receptors don't express equally throughout the 24-hour cycle. Melatonin's the best example. We express more melatonin receptors at 3 a.m. than we do at 3 p.m.
Hmm.
They're changing throughout the day. So we develop drugs with respect to this generic situation. We have no physiologically in drug discovery development. And then we give the drugs to people with the assumption that everyone just responds the same way. But it's a very open, testable hypothesis that maybe circadian will affect drug efficacy or drug tolerability. This is not outrageous. I'll give you an example. So we know that people who take acetaminophen overdoses.
Hmm.
We
Right.
know this is not uncommon. We've all done ER rotations and things like that. And people sometimes it's accidental. They take too much acetaminophen and they come into the ER. We all know that the metabolite of the acetaminophen is highly hepatotoxic. It's a very
Hmm.
highly hepatotoxic, and it has to be biodegraded by one of the antioxidative enzymes, which quickly is used up by the liver. Anyhow, we know that that metabolite is produced by cytochrome P450-2E1. Now, that particular cytochrome shows us a circadian rhythm. And what's so interesting is that Tylenol overdose in a rat is much more hepatotoxic at the end of the day than it is at the start of the day. Isn't that interesting?
Hmm.
And so that does suggest that the kinetics and the dynamics and the toxicity of drugs, that is how they're being biotransformed in the liver, may be affected by our biologic rhythms. I find that pretty interesting.
It is. And how does that play a role, say, in adherence for our patients in taking medications? Develops here in the rodent. Can we
Yeah.
go through that? What does that role play for us?
Yeah, I think that, look, people stop taking medications for a variety of reasons. There's at least a
Hmm.
dozen, if not more, reasons. We
Right.
tend to gravitate to efficacy and tolerability, but we appreciate it's more complicated than that. But on this reductive efficacy tolerability, those two variables, which are important, not the only two, there's no doubt that people tend not to take medications that they perceive as not as efficacious that they would have hoped
Hmm.
for. And they tend, of course, not to take medications that they feel the risk benefit ratio is not worth it. And there's no doubt that there's examples in other areas of medicine. There's a lot of work been done in oncology, actually, showing that the tolerability of many drugs, we can agree that cancer therapeutics are not pleasant,
Yeah.
and their unpleasantness, keep that word going, is even greater at some times of the day than at other times of the day. We just haven't studied this in psychiatry. As you know, Jerry, we have in fact now ways we can measure this more easier, reliably, objectively, ambiently with actigraphy and so on. It's a matter of time before people are going to start looking at efficacy, tolerability throughout the day. And that's
Yeah.
interesting. And that's a nice segue to chronotherapeutics because chronopharmacology is the effect of the circadian on pharmacology, that is kinetics and dynamics, but chronotherapeutics are interventions that target the circadian system. Of course, lithium comes to mind immediately, melatonin comes to mind.
Hmm.
Well, you could even say that CBT, insomnia, maybe IPT, social rhythm therapy, maybe they're also chronotherapeutic. So this type of new language, I think, is going to catch on because there's been so much interest now in passive ambient technology to measure aspects of circadian. And that technology, I think, is going to sharpen our focus, give us the granularity to fill in what's been a known unknown, and that is what is the effect of efficacy and tolerability of psychiatric drugs throughout the day.